Welcome to the Libido Lounge, where we focus on all things love, lust, and libido. We believe that fabulous sex is important to health as exercise and good food. Hi, everybody. Welcome back to another episode on The Lounge. I'm your host, libido expert, Dr. Diane Mueller, and I am so excited about this conversation today. I have with me a dear friend, Dr. Yvonne Carney, and we are talking today about anxiety, libido, breast cancer, and more, because one of the things Dr. Yvonne and I were talking about offline is how much anxiety is such a key thing that can get in the way of a healthy sex drive. And what causes anxiety? So many things, but a huge thing for women is the dreaded mammograms, the dreaded breast cancer, the pain, the stress, all the things that come with this. And so I'm so excited to have this amazing woman here with me today, the gynecologist turned integrative practitioner. Welcome, 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 my friend. I'm happy to be here with you today.
Thank you, Dr. Diane. It's my pleasure, and it's so great to be with you and talk to your tribe.
Thanks. So let's start initially. We're going to link this all to libido and link this all to solutions and imaging and problems with mammograms and benefits, and going to break down that whole thing. But I think you have a really interesting story of being very traditional from a standpoint of gynecology and then becoming more so holistic and more integrative in your approach. So can you tell us a little bit about your story and why you left that real traditional gynecological model?
Absolutely. It is a story, and it was not an easy leap for me to take. I was grounded, and I really believed in the traditional approach. I was actually in the United States Air Force. I was a military doctor. So I was used to, follow the rules, say yes, ma'am, yes, sir, and do the algorithms. And I could quote all the studies about why we do what we do, randomized clinical trials. And when I got out of the military and started my own practice, as I started really caring for more women, I realized that I didn't have answers for them when they would ask more questions. And so there was some aha moments of things that I was doing that, all of a sudden these recommendations would change. And one of them was with hormone replacement, because had just started my practice back in 2003. So I'm dating myself, but that's okay. When the Women's Health Initiative came out and all women got off their hormones because they were afraid of breast cancer. And then I was through that whole debacle of people stopping their hormones and then suffering. And then is there a better answer? I had to go through the question of the medicines they use for osteoporosis or osteopenia, which then all of a sudden there was this black box warning that came out that said, oh my gosh, you got to stop using them after 5 years because they increase the risk of atypical fractures. And I was like, how can they be good for you for 4 years and 11 months? And all of a sudden at 5 years, they have problems. So all these little doubts started rising in my mind. And then as I was doing with mammography, as a gynecologist, I would give people hundreds and, all my patients over 40, right? Get your mammogram, get your screening done. You're trying to take care of yourself. You don't want cancer. And so I was doing all these things, but in the back of my head was this little what about radiation from mammography? Isn't that a risk for cancer? But, I'm following the algorithms. I'm doing it right.
Yes.
But then as I started to really question and look deeper at all of these things, I realized that I didn't have the tools in my toolbox to help the women I wanted to help. And so that's when I started looking at functional medicine and integrative medicine and spending more time with my patients to really get to know them. And then I had to leave my practice because we were lined up to do, 25, 30 patients a day, 15 minutes max, run them through. And so in 2016, I left and started my own practice. And then as I've been learning more and more over time, that's when I started to realize this, wow, women need to know this stuff. Women need to be able to make informed decisions on their own. And so many women rely on their doctors to tell them the right thing to do because they want to be good patients, right? And so yet one of the key factors to medicine, any medicine, is informed consent.
Yes.
And so when you have informed consent, you're relying on the intelligence of the individual to make decisions about their own health when you give them information about risks, benefits, alternatives, and limitations. And so once I really started realizing that that's missing in a lot of our healthcare for women, and particularly with breast cancer screening.
Yeah, I was talking to somebody yesterday about the Latin root of the word doctor, which is
Teacher.
to teach, right?
Not just hand stuff and do this, do that.
So it's like that informed consent, right? I look at that as like, well, this is as doctors, this is basically the Hippocratic oath we take in part, is like to actually teach people what is happening and help them make the best decision for themselves. So, and I think this conversation is so important because what you brought up too around hormones, I feel like two of the things that give women the most anxiety, I feel like in their health and like the midlife ages are, one, do I need to be on HRT? Is it safe for me? And two, what do I do about mammograms? So it's really,
or just breast cancer in general,
True.
Because it is important to take control of your health. So the first thing you have to decide is, do you want screening? Right.
Yeah.
And if you want screening, what are your options? And there's only one that's traditionally approved, and that's the mammogram. But a lot of women, this is a statistic that was kind of scary, is that 35% of women in the mammogram age range don't get mammograms. 35% have decided against it. And so what do they do? Do they just not do anything and wait? Or is there something else for them?
And that's why this conversation, I think, is so important. And so let's break this down one at a time, like from a standpoint of informed consent, right? So using that as our kind of jumping off point, what do you feel from that standpoint are like the biggest benefits, risks, limitations of the mammogram? And then we'll talk about other solutions after.
Great. Okay. So benefit, theoretically, well, no, it has been that the benefit of breast cancer screening is to detect cancer before you feel a lump. And the thought is that there's a 5 to 10 year gap between when something would first be detectable at imaging and when you're going to feel a lump. And so during that 5 to 10 years, things can progress and spread. And so the goal of the screening, the breast cancer screening program, is to detect cancer early when it's easier to treat. And hopefully also that will extend the woman's life. But that's a little debatable, as to whether or not life expectancy is actually increased with mammography or with breast cancer screening. But easier to treat is very important because if you catch it early and you get a lumpectomy, which is just removing the tissue, the tumor with the margin around it, versus if it's later and you need mastectomy, so the whole breast removed plus chemotherapy, that's a huge difference.
Yeah.
Right. And so there are, even if it's not necessarily lengthening the life, I think the easier treatment is crucial. And so that's the goal of the screening. And that's the benefit. The risk what a limitation means is like we don't really, it doesn't necessarily cause harm, but it's stuff that it might not do. Right. So there's a difference between limitation and risk, because risk implies the risk of harm.
Yeah.
Right. So limitations, there's several. One is that for women with dense breasts, mammogram doesn't work very well because the mammogram is an X-ray of the breast and it's looking for abnormal calcium deposits and clusters. And that happens because if you picture something that's really disorganized, that's the way the blood vessels are in a little tiny cancer tumor. They're completely disorganized. So because of the way they're laying all over each other like this, they cause calcifications. And not all calcifications are cancer, but that's what a mammogram does, is it picks up calcifications and then it's decided if they're concerning in appearance to get a biopsy. But when you have dense breasts, that means you have more fibrous tissue and it turns up white and bright also. And so these calcifications can get hidden. And mammograms miss 50% of cancers in women with dense breasts, up to 50%. And 40% of the population has dense breasts, and especially the premenopausal patients. So in the age range of 40 to 50, where mammograms are starting at 40, there's a 10-year period or more where you're going to have more dense breasts. And for people with a family history or genetic predisposition to cancer that start their screening earlier, they almost always have dense breasts. So it's not ideal for that. And so now we're the United States Preventative Task Force, the recommendations are to include a handheld ultrasound with a mammogram for those women with dense breasts. But a lot of times insurance doesn't cover that part. And so the handheld ultrasound is very grainy, but it's better than, we're just looking at what we have available. So it's better than just the mammogram, which has things missing. So that's a big limitation.
And then a question about that, because in that I hear like, okay, a huge limitation is a false negative, right? But then I've also read reports of actually a substantial amount of false positives.
That's the other limitation. Perfect.
Okay.
Yeah, big limitation. In fact, 90% of abnormal mammograms are false positive.
90%?
90%. I'm super happy that those 90% of the women don't have breast cancer. I'm so happy for that.
Yes.
Right? So, and usually they're so relieved that they don't have cancer, that they don't stop to go, geez, Louise, what did I just go through to prove that I don't have cancer?
Yeah.
But when you have an abnormal mammogram or the radiologist just is not sure, right? Then what happens is you get called back for additional views. And it could be another mammogram with what they call spot compression views. It could be an ultrasound plus a mammogram. It could be an MRI with IV contrast using a heavy metal called gadolinium, or it could go straight to biopsy, or it could go down all four of those, right? Start at the top and work your way down to the biopsy, because the only way to know for sure that it's not cancer is with a biopsy, tissue sample. So think of that though. My first mammogram was abnormal when I was like 40, and I was so anxious during that 2 to 3 week period before I finally got the all clear. Like, oh my gosh, what if it's cancer? What am I going to do with my kids? How am I going to continue working? So the anxiety during that period is significant. And you and I, as integrative doctors, realize the stress component affects your health. And so it's not just oh, you're worried. I'm sorry, you're worried. There's health consequences to anxiety.
Exactly.
Right?
Exactly. And sometimes we start down that fear trajectory. And even when we get relieved around, okay, well, that was a false positive, it doesn't mean that fear hasn't already taken a toll on us.
And then there's the risk of the procedures to prove you don't have cancer.
Yeah.
Which is, I had a patient in my practice just a few months ago. She had her mammogram. She had to go back for a biopsy. The biopsy came back all clear. She was very relieved. However, she got a huge breast hematoma, which is a collection of blood because they hit a little vein where they were trying to get the sample. And she required a drain and surgery to get rid of the hematoma. So she's glad she doesn't have cancer, but she went through a 2-month process of pain, surgery. Now she's got all the scar tissue inside from the hematoma, and all to prove she didn't have cancer.
So then I appreciate too the differentiate between risk and limitations. I'm also curious though, like, do you feel like the radiation is a risk? As far as, do you think that's
proven? Yes, unfortunately, it's proven. So there is a study because, we know that radiation causes cancer.
Yeah.
Now, this is where risk and benefit comes in, right? So
yes,
I believe that the traditional doctor that is following the algorithm in their heart, they're saying, yes, but the benefit of early detection outweighs the risk of the radiation. I know they wouldn't. In my heart, I don't believe they're doing something that they would cause harm. But the problem is the system does not educate the woman that there is risk.
Right.
I never knew it, right? I didn't educate women about, yes, there is a small amount of radiation and it does have a risk, but here's why we want you to do it anyway. I just handed women prescriptions and the doctors now, it's like, women are almost shamed or coerced if they don't get their mammogram, right? Like, you fool, you're inviting advanced cancer. Don't you care about your family? Don't you care about your children? And nowhere I would challenge the listeners to say, last time I got a mammogram, or any time I've been given a prescription for a mammogram, did the doctor handing you the prescription discuss potential risk with you? I would guess no. And I didn't even know about this. Once I started researching it, I got mad because I've been a gynecologist for 25 years. And how could I not know this? But there's even a study, and it was out in the early 2000s, and they looked at atomic bomb survivors, and they calculated the risk that for every 100,000 mammograms done, there will be 88 radiation-induced cancers and 11 cancer deaths.
Yeah.
And so that's small per 100,000, but it's not negative. It's not negligible. And there was another study that came out afterwards, which was very disturbing, that said it's probably higher than that, because this was done looking at atomic bomb survivors, and it's a different type of radiation from an atomic bomb than the lower frequency radiation from a mammogram. And this study said that the lower frequency radiation or the lower energy radiation from a mammogram is 4 to 6 times more likely to cause DNA damage and mutations than the gamma radiation from nuclear bombs. So if you take 88 and times it by 4 to 6, now you're in the hundreds, 600. And that is not insignificant. So why not let the women know this and let them make their informed decision? If you want your mammogram, I support you. You know, we'll do what you need to do, get your mammogram, get your peace of mind, but at least be given the option to weigh things.
Yeah, I know that it's not just this no problem, no side effects, no limitation, any of that. Know that you're going into it making the best decision because you have that full rounded knowledge. So,
and it also depends on if there is other modalities, right? Because, you know, up until recently, there hasn't been a lot of choice. It's okay, wait until you fill a lump, which is 5 to 10 years later. And by then it's about a centimeter in size, which is significant. Or some women will get thermography. And that is, you know, that's the study of heat, which in the physiology of cancer, it is going to find abnormalities because of the rate that cancer grows, and because cancer is inflammatory, it will show up heat around an abnormal area. But so will a mosquito bite, so will a pimple, so will a upper respiratory infection or a sore throat. I mean, so it's sensitive, which means it picks up everything, but it's not specific, which means yes, it's concerning for cancer. So and it's not really looking at the structure of the breast; it's just an outline looking at heat. And
amazing. Super helpful.
But when we're trying to decide of, oh my God, I'm not going to get a mammogram and I don't want to do nothing. Okay, so I'll do a thermogram. But now there's the new technology,
which I'm so excited about. It's going to change breast cancer screening. So tell us about this.
So this new technology is not actually that new. A little history on it. It's called QT imaging, which stands for quantitative transmission. It's undergoing a name change right now. So pretty soon it's going to be called breast acoustic CT. But it was developed by a very brilliant doctor in the 2014, 2015. He was given a grant from the National Institute of Health over time of over $20 million to try to find an imaging modality with less risk that was very reliable and cost effective. And so this is using the speed of sound through tissue. So it's more than just traditional ultrasound. It actually uses both traditional ultrasound and the speed of sound through tissue. And it looks similar to an MRI. So it gives you actual structure, but also functional physiologic evaluation of the tissue. It can look at things, a few stacked cells will show up on this QT scan. And it can tell the difference between fibrous tissue, fat tissue, fluid, and very good at even up to predicting what the histology would look like on biopsy. There's no compression, no radiation, no IV contrast. You lay on your belly, and there's a little hole in the table, and you're lowered into a warm water bath that's body temperature, so it's not uncomfortable. The only discomfort that people sometimes have is because the way the ribs hit the circle, and you have to turn your head. So people, honestly, I can't say it's no pain at all, because if you have neck issues and it's hard to turn your head for 10 minutes, you might feel a little uncomfortable, a little bit of discomfort, but there's not the squish, right, that you get with the mammogram.
Yeah. So
there's no, for women who have implants, there's no risk of rupture of the implant, which can happen with the mammography.
Right. And then it sounds like it's much more specific, right? So it takes care of that problem too.
It actually it's true 3D imaging. It's the only true 3D imaging that we have for breasts. All the other stuff that they say, well, I had a 3D mammogram. That's not really 3D. What they're doing is they're stacking images on top of one another and approximating a 3D, but there's gaps that are computer generated to fill in the gaps. Just like pixels on a screen, the higher the pixels, the less gaps. But these, those 3D images are approximate. This is true 3D imaging, and they can actually measure the volume of the breast. And so it's used to, they're using it to monitor like treatment response to tumors, because it's so good at measuring volume that within 2 to 6 weeks, they can tell if something's growing or shrinking.
Oh, it's amazing. Relief. Yeah, it really is. It's going to completely change how we both test, monitor, treat, scare, the fear, all of it. I think it's like the level of change from this modality is just phenomenal. And I know you have one in your practice now, right?
Yes. I've been on a mission for the last 2 years to bring it, because, it got its FDA, devices are FDA cleared. So it's not FDA approved. I learned this. Drugs and medicines are FDA approved. Medical devices are FDA cleared. So this is FDA cleared. And it's particularly got an indication for women with dense breasts, because it's very good. And they did some of what they call non-inferiority studies comparing it to mammogram for women with dense breasts. And it excelled. It was very good at that. The company right now, they're saying that we're not intending for it to replace mammogram, because that mammogram industry is very solid.
Right.
But my perspective is, what about the 35% of women that have already decided against mammogram?
Absolutely.
Now they have something. And then over time, we'll see what happens. We had to bring this to the women from a grassroots level. The hospitals and radiology centers are not interested. And so when there's a few doctors around the country who have become passionate about this, and we're like, we're getting it and we're offering it to women. And so in my practice, we're like, you don't even have to be a member of my practice. We will bring women from wherever, and they can just book a scan, and we'll send the results to their doctor, which unfortunately their doctor may not know what to do with them, because we're trailblazing. But at least the woman has the report to say concern, not concern, And over time, we will develop that relationship. We will develop the ability, and through more and more women having the studies, the relationship to say, oh yeah, look at this. I think over time it will be much more accepted, but I didn't want to wait 10 years for radiology centers to offer this.
Oh,
I think women need it now.
Important. Well, and we start the change, right? We start by change by actually becoming the change, by making the change, not by waiting for it. So it's just such an invaluable resource. I know we are out of time, and I know so many people are going to have questions for you and be curious about getting a QT scan. So we're going to make sure we have your information as far as your clinic, how to get a hold of you. All of that will be in the show notes. And I also want to make sure that another way that people can connect and just learn from you is by taking your hormone quiz.
Yeah.
So we'll put that in the show notes as well. I believe that's totally free, correct?
Yes, it is. It's a kind of a robust quiz. So it's not like answer these 6 questions and I'll tell you what hormone imbalance is, because we really want to give you valuable information. There's 64 questions.
Good.
But then what you really get is you're honing in on which symptoms of how many different imbalances you have. And then it's an education process that goes afterwards. So that's completely free, and it's on my website. And for the breast imaging, we tried to make it easy. So I'm in the Chicago suburbs. They can either find it on my website, or I actually bought the URL chicagobreastimaging.com so that women could just remember that and find the QT imaging link to get Eventually we'll have the ability to book online, but right now we're just requesting an appointment, and then my team is calling to get them arranged.
Perfect. Yeah. ChicagoBreastImaging.com. What a great URL and easy to remember and all of that. Yeah. Well, thank you so much for being here. It's such a pleasure. And just, it's so good to have you as a resource, in the community to help educate other docs like myself, as well as so many people. I think it's just the number of lives that are going to be saved, and the fear and the anxiety that's going to be reduced by this technology and your offerings is just so huge. So thank you so much.
Thank you.
And everybody, this is another episode of The Lounge. Remember that in 2024, what we are doing is the person that has the most downloads, the most likes, the most shares, we're going to invite them back at the end of the year for a super duper deep dive. So I hope to have Dr. Yvonne back with us. So please do download, share this with your friends, spread the word. So many people need this information. And I am now signing off, reminding you to stay sexy, stay classy, always be a little badassy. See you next time. Thank you for listening to the Libido Lounge. Please don't keep me a secret. Please share this with your friends. You can find me on YouTube, on Instagram, as well as how to work with me at mylibidodoc.com.